Good morning, everybody. My name is Dr. Sharat Krishnaswamy. I'm a neuroanesthetist, and today I shall take a class on transcranial Doppler. This module will cover the history of transcranial Doppler, the physics of Doppler, transcranial Doppler windows, the technique of conducting a TCD assessment of a patient, the normal spectral waveforms, TCD variables, as well as abnormal patterns. Coming to the history of transcranial Doppler. It was Rune Astlett in 1982 who introduced the transcranial Doppler, and this was used for detecting blood flow in the basal intracerebral arteries. Later on, the power motion mode Doppler with 33 sampling gates was invented by Mark Mohering in 2002, and this is what we will be using today. The TCD was initially introduced to detect vasospasm following subarachnoid hemorrhage, and that is one of the primary reasons we use the TCD in the neurocritical care ICUs today. I was curious about what sampling gates were. So what are sampling gates? Basically, ultrasound is based on echoes. A sound that is transmitted, it needs to be reflected and received by the probe. And this happens at a narrow time interval after transmission, and it corresponds to a specific depth. And this contributes to the Doppler signal. So the user defines a small area known as a sample volume or gate within the B mode image, which stands for brightness. And this gates allows the precise measurement of blood flow velocities and patterns, and this helps in aiding the diagnostic assessments of the condition of the patient. What are the gate parameters that we have to define while applying this system on the patient? So the gate parameters are selected by the operator, and the axial size of the sensitive volume and the depth of the sample should be adjusted. So if you can look here in this diagram, you see the operator defines the sampling area. The dotted line here indicates the direction of the sampling, and the parallel horizontal lines here, it marks the axial extent of the sensitive region. So using this axial length, we can calculate the apparent velocity as well as if there's any stenosis or increase or decrease in the velocity of the blood in the blood vessel. What are the uses of the transcranial Doppler? As I said before, this can be used to check the cerebral arterial patency, to detect stenosis, to look for collateral flow patterns, to see the effect of embolization on the artery. And it also provides real-time information about the cerebral hemodynamics over extended periods of monitoring. Combining the transcranial Doppler and the cervical duplex ultrasonography, we can also estimate the consequence of extracranial carotid artery stenosis. And we can identify lesions that can respond to interventional therapy. The other applications of transcranial Doppler is to detect the right to left shunt in the method of identifying cerebrovascular reactivity, to measure the flow velocities for stroke prevention and sickle cell disease. It is used as a supplementary diagnostic test for brain death. And in ischemic stroke, it is used to enhance clot dissolution and systemic thrombolysis. Coming to trying to understand what the basic ultrasound physics behind Doppler is. So Doppler follows the pulse echo technique. This is when pulses of sound waves are sent to the tissues and the echoes are reflected at different structural boundaries. These reflected waves are received and are processed to provide the meaningful information. This happens when electric current is passed through a piezoelectric crystal in the transducer. This vibrates to generate pulses to ultrasound waves of a specific frequency. This frequency of echoes that is emitted after striking a moving object are different but from those that are emitted from the source. So the difference between the transmitted and the reflected sound frequencies is known as a Doppler shift. And this helps us in detection of the tissue motion and the blood flow. So these complex signals that are resulting from the reflection of the moving red blood cells, they are broken down into individual velocities by a method known as fast Fourier transformation. So if you can look here, the reflected sound wave is of a higher frequency than the emitted sound wave due to the electrocyte movement. Whereas the reflected sound wave here, when the electrocyte, that is the RBC, is moving away from the transducer, is of a lower frequency than the emitted sound wave. So while we are insonating a patient with the transcranial Doppler probe, we have to make sure that the angle of insonation, that is the angle between the ultrasound beam and the blood flow, is apparently zero. Here you can see it's in a straight line, so the angle of insonation is zero. If you can look at this diagram, you see what the Doppler shift means. that is directly proportional to the velocity of blood and the cos theta. Cos theta is the cos of the angle of insonation. Here, theta is the angle of insonation. If you can look here, the ultrasound beam is transmitted to the moving blood in the blood vessel, and the angle it makes is of an acute angle. If we can look here, there is no angle produced by the moving blood and the emitted sound waves, where the cosine 0 degrees is equal to 1. If you can look here in the third diagram, the cosine of 90 degrees is 0. Here, the cos theta is 90, the theta is 90 degrees, and hence the cosine of 90 degrees is 0, and hence it will not be possible for us to obtain necessary information to process the Doppler shift in this patient. So using Doppler on the cranium has its own set of challenges. This is because the skull attenuates 90% of the sound waves, and the attenuation is lower for the lower frequency sound, which is why we use lower frequency sound to try and insonate the blood in the blood vessels of the brain. The transcranial Doppler uses a 2 megahertz ultrasound to enable the test performance. So if you can look here, the difference between a high frequency waveform and a low frequency waveform, a low frequency waveform can penetrate the tissue and the cranium better, and hence get the necessary information needed to assess the blood flow. Moving forward to transcranial power motion mode Doppler, this simultaneously displays flow intensity and direction over 6 centimeters or more of the intracranial space. And it uses 33 overlapping sample gates to give information about the entire length of the artery, the various bifurcations, everything on a single screen. So this makes the performance of the TCT examination relatively easier even for an experienced operator. Moving forward to the different transcranial Doppler windows. So in some areas of the skull, the bones are relatively thinner and it allows the penetration of the ultrasound. The commonly employed acoustic windows in adults are the temporal window, the orbital window, the sub-occipital window or the transforaminal window, which is basically below the foramen magnum, and the submandibular window. The transtemporal window helps us in assessing the flow velocities in the middle cerebral artery, the anterior cerebral artery, the posterior cerebral artery, as well as the posterior communicating artery. The transtemporal window helps us in assessing the flow in the ophthalmic artery and the internal carotid artery. If you can look here, this is the part of the internal carotid artery, which is known as the ICS siphon. Moving forward to the sub-occipital window. So the sub-occipital window is also synonymous with the transforaminal window. There is a natural defect between the occipital bone and the atlas vertebra, which forms the sub-occipital window. So this helps us in the insonation of the vertebral arteries and the basilar arteries. So the transforaminal approach is a direct insonation through the foramen magnum. When it comes to the transtemporal insonation, there are 3 points of contact where you can insonate the middle cerebral artery in the transtemporal window. So that is the middle, this is just above, in front of the tragus, just above it is the posterior, and just anterior to it is the anterior position to do the insonation for the transtemporal insonation. There is another insonation technique, which is a submandibular approach. This is used to evaluate the distal cervical internal cerebral artery, internal carotid artery. And this is used for evaluating vasospasm in patients with subarachnoid hemorrhage. So if you can look here, there are 2 ultrasound probes, that is the transcranial Doppler probe and the transcranial color duplex probe. You should always reduce the amount of power that you use while insonating the ophthalmic artery during the transorbital window. This diagram shows the major intracranial arteries and the flow direction of the various arterial segments, as well as the depths of insonation in an average human skull. So if you can look here, the internal carotid artery is at a distance of 65 millimeters from the point of insonation, as well as you will find that the ACOM artery is 75 millimeters. The P1, P2 is at the distance of about 100 plus millimeters. The basilar arteries are at the distance of about 90 and 80 millimeters. So how will we do the transcranial Doppler examination technique? You will have to make sure you're seated in a comfortable position at the head of the patient. Make sure the patient is comfortable and lying supine with his eyes facing the ceiling. The anatomic segments that you have to identify are the depth of the blood flow, the direction of the blood flow, and the Doppler spectra. So the depth of the blood flow will help us understand which artery we are trying to insonate. The direction of the blood flow will also help in further the same. And the Doppler spectra will help us figure out whether the flow is towards the probe or away from the probe. Coming to the transtemporal insonation. So you begin by placing the 2 megahertz TCD ultrasound transducer over the temporal area, just above the zygomatic arch and in front of the tragus of the ear, and orient the transducer slightly upward and anteriorly. You have to adjust the probe so that the power mode Doppler screen is filled with color signals between 30 to 80 millimeters of depth. If you can notice a color signal which is red and it is towards the probe, between 40 to 65 millimeters, it shows the flow in the ipsilateral middle cerebral artery. The blue signal between 65 and 80, it shows the flow from the ipsilateral ACA, which is not shown in this picture. So it is also important to know the different parts and the classification systems of the various arteries. That is the middle cerebral artery, anterior cerebral artery, and the posterior cerebral artery. If you can look during the distribution of the branches of the middle cerebral artery, the middle cerebral artery is divided into 4 segments. That is the sphenoidal segment, the insular segment, the orbicular segment, and the terminal of the cortical segment. So the sphenoidal segment known as M1, in which you can see the flow of blood towards the probe, whereas the insular segment is away from the probe, as well as the orbicular cortex segment is again towards the probe. So it is important that you will have to identify the flow of blood at a region where there is not branching of the blood vessel, and there's at least a 2 centimeter persistent unidirectional flow of blood in the blood vessel. Coming to the middle cerebral artery, the middle cerebral artery lies at a depth of 40 to 65 millimeters. It is dependent on the size of the patient's head. It bifurcates into 2 divisions at the depth of the 40 to 45 millimeters. Like I mentioned before, there is a branch that goes superiorly and the branch that goes inferiorly, both of the M2 segment. The flow signals from the 2 M2 MCA branches are obtained by orienting the probe as if going with the flow. So it is important to have an idea about the patient's anatomy of cerebral circulation while you conduct the TCD examination. The ICA bifurcation, that is the internal carotid artery bifurcation, is seen at a distance of about 65 millimeters. And you will see a bidirectional signal at 60 to 70 millimeters, which represents the ICA bifurcation. The ACA flow is always away from the probe. If you can look here, it is below the baseline and it is in blue, which means the flow is away from the probe. So this is how you will identify the anterior cerebral artery. Coming to the internal carotid artery, this is required when you have to compare the velocities of the middle cerebral artery and the internal carotid artery. So it is important for us to understand the various branches of the internal carotid artery. If you can see here, the Boutelier classification divides the internal carotid artery into 7 segments, which is the cervical segment as C1, C2 is a petrous segment, C3 is a lacetum segment, C4 is a cavernous segment, C5 is a clinoid segment, C6 is the ophthalmic artery, and C7 is a communicating artery. So this internal carotid artery terminates into the anterior and the middle cerebral arteries. Moving forward to identify how the probe will have to be insonated for the posterior cerebral artery. Once you obtain signals from the middle cerebral artery and the anterior cerebral artery, the ultrasound probe is oriented posteriorly by 10 to 30 degrees. So usually there will be a flow gap followed by flow signals from the posterior cerebral artery. And the flow signals directed towards the probe represent the P1 PCA, whereas the flow signals that arise away from the P2 segment of the PCA. And both these segments can be visualized at depths of 55 to 70 millimeters. And both are dependent on the probe orientation. So again, it's important to know the anatomy of the posterior cerebral artery. So the posterior cerebral artery can be divided into the P1 segment, the P2A segment, P2P segment, the P3 segment, and the P4 segment. So the posterior cerebral artery arises from the basilar artery. A different diagram which can give a better understanding of this is here. So it is a posterior cerebral artery is a terminal segment of the basilar artery, and it gives rise to the posterior communicating artery within the interpendicular cistern. So here's the interpendicular cistern. The P2A is the segment within the crural cistern. The P2P is the subsegment in the ambient cistern. And the P3 is the segment of the posterior cerebral artery in the quadrigeminal cistern. And the P4 is the cortical segment of the posterior cerebral artery. Now that we have done the transtemporal insonation, we can also try and do the transorbital insonation. Usually no harmful effects are seen with a diagnostic TCD, but it is important to reduce the power output to 10% or less. This is used to evaluate the ophthalmic artery in the ICS siphon. You place the transducer gently on the patient's eyelid, and it is angled slightly medially and upward. If there is a flow signal at the depth of less than 60 millimeters with higher resistant pattern, and if it is towards the probe, then this represents the ophthalmic artery. The ICS siphon, as I have mentioned before, is nothing but a complete bend in the flow of the blood vessel, and it is a complete 180 degrees change in the flow of the blood vessel. The transorbital approach, as I have mentioned before, the sample volume has to be moved beyond the 60 millimeters depth to obtain signals from the ICS siphon. Since the ICS siphon is a curved artery, the flow signals may be either directed towards the probe or away from the probe. Moving to the sub-occipital installation, you can turn the patient to one side and place the transducer just below and medial to the mastoid process. You direct the probe slightly medially and more horizontally towards the bridge of the nose or the contralateral eye. And this orientation will help in obtaining the flow signals from the ipsilateral vertebral artery between the depths of 50 to 75 millimeters. And the signals are always away from the probe. This is another diagram explaining how to do the sub-occipital insonation. If you can look here, both the vertebral arteries join together to form the basilar artery. And over here, it mentions that the flow is away from the probe, which is why it is in blue. How will you identify the basilar artery? The basilar artery is insonated through the sub-occipital window by going with the flow of the ipsilateral vertebral artery, by turning the probe slightly upward and medial from the depths of 75 to 110 millimeters. So you place the transducer just below the occipital protuberance and orient it towards the nasal bridge, which is known as the transforaminal window, and you will obtain the basilar flow signals. So if you can see here through the TCCD, the flow from the basilar artery is away from the probe and hence below the baseline. Now that we have looked at all the different various windows used to assess the different arteries in the brain, we shall try and see the Doppler spectra. And this will give us important characteristics about the flow in the arterial spectrum. And based on the spectral these patterns, we can identify the cerebral hemodynamics in normal persons as well as patients in disease states. So if you can look here, the normal spectral waveform, it shows a sharp systolic upstroke and a stepwise deceleration with a positive end diastolic flow. It's not below the baseline. The upper mode shows an M mode, which is the motion mode of the various arteries. If you can look here, the red signal up to 65 millimeters means the flow is towards the probe, and from the 65 to 80 millimeters, it is away from the probe. So the flow towards the probe is the middle cerebral artery. Away from the probe is the anterior cerebral artery. And a red color beyond this 80 millimeters, it shows the flow towards the probe, which is the contralateral anterior cerebral artery, and beyond the probe, beyond 80 millimeters and further on is an indication of the contralateral middle cerebral artery. So if you can look here, you can see that a normal TCD spectrum, it shows at a depth of about 47 millimeters, rapid systolic acceleration and stepwise deceleration. Now there are few calculations that may be made to identify few parameters that we use to assess and understand the condition of the patient. So I will keep describing them as follows. One is the peak systolic velocity, and it is measured in centimeters per second. This is the first peak of the TCD waveform from each cardiac cycle. A rapid upstroke, which means that there is no narrowing or no stenosis between the insonated intracranial artery segment and the heart. An end diastolic velocity is also measured in centimeters per second. It lies between 20 to 50% of the peak systolic velocity. It shows a low resistance intracranial flow pattern, which is seen in all major intracranial arteries. A mean flow velocity, which is quite important in assessing whether the patient has vasospasm or not, is given by the calculation of end diastolic velocity plus 1/3 of the peak systolic velocity minus the end diastolic velocity. Amongst all the arteries, the middle cerebral artery should have the highest mean flow velocity. Next is the pulsatility index. This is to assess whether the patient has flow resistance in those arteries. And it is given by the formula pulsatility index is equal to peak systolic velocity minus end diastolic velocity divided by mean flow velocity. This is the most commonly used TCD parameter to determine the flow resistance. And if a patient has a value of pulsatility index more than 1.2, it represents high resistance in blood flow and a possible stenosis of the artery. Now, the resistance index is another TCD parameter used to assess the flow resistance, and it represents the flow resistance distal to the site of insonation. The resistance index is given by the formula peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. And any value below 0.75 is normal. The other measures are the systolic diastolic ratio, which is not generally used for clinical purposes, as well as identifying the heart rate of the patient. It might influence various flow parameters, and it is noted on the typical TCD spectra. Coming to abnormal flow patterns, and you will find the spectrum of abnormal systolic flow acceleration. So when a patient has a particular stenotic lesion, the patient might have a vasodilatation post the stenosis to allow increased blood flow to the region. So such patients will have a delayed systolic flow acceleration, flattened systolic upstroke, and slow diastolic deceleration. So this delayed systolic flow acceleration of flattened systolic upstroke with a slow diastolic deceleration, this is a hallmark of stenosis proximal to the site of the pulse wave Doppler. And this is known as blunted flow, and it is due to compensatory vasodilatation distal to the stenosis. Describing to you a few more examples of a delayed systolic acceleration. If you look at the figure B, it shows an elevated flow velocity, so mean flow velocity greater than 100. So this is a possible stenosis in the patient. The figure C described over here shows a flow spectra obtained in a middle cerebral artery with a stenosis of greater than 70%. Here, the white arrow shows the flow turbulence of Brui, and the patient has a spectra with irregular rhythm and flow velocities. This patient has diagnostic of atrial fibrillation, where the patient has irregular rhythm and flow velocities. And E shows alternating flow signals, which is characteristic of cerebral circulatory arrest. Cerebral circulatory arrest, if you can see here, it is a hallmark of brain death, and it varies from high resistance to diastolic flow reversal reverberating or absent flow. And this TCD is often used as a supplementary test for the confirmation of brain death. So if you can look here, the diastolic flow pattern is generally supposed to be above the baseline, but here it is seen below the baseline. And here you can see a particular sign known as a hot nose sign seen in brain death. So when would you identify whether the patient has moderate stenosis? If you can look here, the middle cerebral artery, anterior cerebral artery, ICS-, posterior cerebral artery, vertebral artery, and basilar artery have all their normal values mentioned here of the mean flow velocity in centimeters per second. The ACA and the MCA, the normal mean flow velocity is less than 80. For the ICS-, it is less than 70. For the posterior cerebral artery is less than 50. For the vertebral and basilar artery is less than 60 and less than 50 respectively. But if the patient has around 50% of stenosis of the artery of the MCA, then the mean flow velocity will be greater than 100. And for the vertebral and basilar artery, you'll find that the velocities are more than 70. And for the ACA, you'll see it's not established, but it's proposed that the cutoff value is greater than 90. Thank you.